Thank you, Natalie. The floor is yours.
Lovely. Can everybody see my slides?
Yes.
Um, I've got it in presenter view, but I'm hoping it's not for everyone else. Is that
No, we just see your slide and your point.
okay? Lovely, good. I can get over the angst then of sharing slides on Teams, which is always the worst bit, I think. So thank you for inviting me to talk. I'm just going to bring a problem really to the room as a clinician, which is a problem that I see quite a lot in clinical practice. So I'm a clinical lecturer in geriatric medicine at Southampton Uni. So I work half my time in the NHS as a doctor, looking after older people, and then half my time doing sort of aging research. So I thought that as I'm bringing a problem, and I figured that there's probably some people on the call who aren't that familiar with aging research, I sort of take a bit of a sort of problem and policy slant, really. So I first of all wanted to just sort of set the scene for those that aren't sort of quite so familiar with the aging research landscape. If you are interested, this is a really useful document. So this is Chris Whitty, the CMO, Chris Whitty of sort of pandemic fame. He's probably the only CMO that's sort of a household name, isn't he? But his annual report in 2023 took a focus on health in an ageing society, so older population, and really thinking sort of in terms of those forward trajectories and thinking about it from an NHS and policy perspective, but also from a research perspective. We all know that our population is aging. You can see in the schematic here that looking from a perspective from England, our populations are going to be aging coastally and rurally. And in some of those areas, we're looking that in the 2040s, over a quarter of that population is going to be over the age of 75. So this is a massive demographic shift that we've never seen the likes of before. And these are a population of people that actually we really know very little about. In terms of their underlying biological mechanisms and how they're living with health. And then the other important thing to say is that we've had huge successes in terms of increasing overall lifespan over the last number of decades, but there's a reason why my specialty of geriatric medicine is rapidly expanding, and that's because we've increased lifespan, but we've also increased the number of years that people are living in poor health. So that increase in lifespan hasn't really equated to people living longer and living well. And the implications of that we are now all living through in terms of, huge burdens on our health and social care systems, because we've got people who are over the age of 75 sort of account for around about half of people who are in hospital, and they account for around 70% of the time or bed days that we talk about. So time spent in hospital, number of days a hospital bed is taken up is taken up by 70% of that is over 75. So we are now living in an era where we've sort of not really planned properly for the change in our population demographic. So that's from a sort of policy and planning level, but also I think from a research level. And he, in his document, really states that research is often excludes older adults and historically has, and he makes the case that they should be the main focus of much of our research if we're thinking about it from a healthcare perspective, because they are the main users of our healthcare. And really the focus in terms of aging research is talking about reducing what we call the healthy life expectancy gap. So we're not really interested in making people live longer now. We've got people who are living over the age of 100. They probably don't need to live any longer than that. And that probably is that nobody is immortal. So there will always be a natural lifespan. But we really want to try and reduce this healthy life expectancy gap. So reduce the amount of time that people are living in poor health. And this is particularly apparent in people who are living in areas of deprivation or are living with deprivation. So you can see on the other schematic, if you're comparing these are for women. So if you compare someone who's living in the most deprived areas of England, they live a shorter life, but they also live a higher proportion of their life in poor health. So we really need to focus in on trying to reduce this healthy life expectancy gap, particularly for people who are living with deprivation. And so I don't think I need to sort of say to all of you that nutrition is really important in terms of that sort of deprivation space. And so that's really sort of a main focus when we're thinking about appetite and introducing appetite from perhaps a different perspective to what you're perhaps familiar with when thinking about overnutrition and obesity. This is really sort of the other side of the coin. So there are around 1 in 10 over 65 who are living with malnutrition who are at risk of it. So that equates to about 1 million people at the moment, and that's only going to rise. And these are really high healthcare users, so they tend to contact healthcare more often. They tend to stay in hospital longer. They tend to be in hospital more often, and they tend to suffer higher rates of complications from being in hospital. So that then equates to a healthcare cost, and it's been estimated that it's around 2 to 3 times more expensive to treat somebody who's malnourished compared to someone who isn't. So there's real implications from a sort of health economics type slant. But then obviously there's a huge high individual cost as well. They have much higher levels of disability and loss of independence, which are really important to older people. And poor nutrition underpins some of the really big age-related conditions that we're trying to grapple with and really still don't understand very well, because these are, you know, a generation or a cohort of people that we know really little about because they're emerging over the last sort of post-war period, really. So it underpins frailty, which some of you may have heard of, and then sarcopenia, which is loss of muscle strength, mass and function, and they develop infections more often. So it's a real problem. But it's a huge problem in that if we find somebody who is already malnourished and they're older, treating them is really difficult because we've sort of already missed the boat, as it were. So that's really where a focus on appetite is helpful, I think, in this space. So I come across it really commonly in clinical practice. Estimates vary. There's been sort of a global estimate recently published that says around about 20% of those living in the community over the age of 65. It's really common in hospital. And there's some reasonable epidemiological studies now that sort of link a poor appetite to reductions not only in overall energy intake, but dietary patterns that we would consider to be important for healthy aging. But that also it's an early predictor of some of these important conditions. So undernutrition being one, but also it has independent relationships with frailty and sarcopenia as well. So it's a really useful focus when we're thinking about trying to prevent some of these aging related health conditions, which is another big shift in the NHS space as well. With the current government, they're very interested in moving from treatment to prevention, but also how we think about treating some of these illnesses. If somebody is anorexic and that's why they have become malnourished, trying to get them to eat more is simply not going to work, because you haven't addressed the primary cause as to why they've developed these problems. So Igor mentioned anorexia of aging. I sort of think of appetite decline in aging as a slightly broader concept. So there's secondary anorexia, which is something that we manage quite commonly in clinical practice. You probably or may have experienced it at some point if you've been put on an antibiotic or something that suppresses your appetite. So you may have experience of that. Or cancer is another really common cause of anorexia in the older population. But I think what is really interesting and that is actually the space that we really need decent fundamental research in, because we don't know how to manage it, is the primary anorexia, or what that I think of as anorexia of aging. So this is very much appetite decline that is related to disruptions due to the age-related processes. So whether that is disruptions to a person's wider environmental or social factors that sort of sit within that eating behaviour space, is one aspect, but actually it's that fundamental age-related disruption to the biological mechanisms that are impacting upon appetite regulation for the individual that we really need a better understanding of. And this is where the ask is really. So some of you may be familiar with this if you work in the aging research space, but there's been a lot of work trying to understand what the primary hallmarks are of aging, to try and understand what those fundamental sort of mechanisms are and how we might intervene. So we can so you can see dysregulated nutrient sensing is down there. There's also dysbiosis and chronic inflammation. But I put this picture up to say that there's a lot of these age-related syndromes are really complex and multifactorial and are related to a number of different processes within the body that we need to be mindful of. But that there's real scope, I think, in terms of trying to understand, for example, something like anorexia of aging. This schematic really relates to a lot of age-related diseases, but we need a better understanding so that we can then, clinicians such as myself, have some sort of tool or strategy or treatment in the future to kind of try and combat these clinical problems. So no answers, only asks and problems for the room. And that's it really. So I will stop sharing.